Laura. Good morning, everybody, and Happy New Year to you. Thanks for taking the time to join us on this webinar. My name is, as Laura says, John Whitman, and I teach at the Wharton School in the MBA Healthcare Management Program. My specialty is aging and long-term care, and I'm very happy to be moderating this program today because personally I've long recognized the importance of and the link between behavioral health services and general medical care. And the benefits that having a combined and coordinated approach can bring. Talk to any primary care physician that's involved with care, and they'll tell you that the benefits are improved patient outcomes, reduced time for recovery, reduced ER visits, reduced readmissions, and of course all that leads not only to improved patient care, but reductions in costs, which is a critical factor in today's healthcare environment. Despite these benefits and despite the obvious understanding that a lot of primary care docs have about this link, our medical system has not really embraced the approach of combining these two, at least not to date. The shift in our nation's healthcare reimbursement system, however, is bringing about some really positive changes. And one of them, I believe, is that link between behavioral health and primary medical care is going to be made and is going to be more important because we need to do everything we can to improve care and to reduce costs. For ACOs, this also is important because it not only produces better outcomes, which is one of the key measurement factors for ACOs, but it can also help improve profitability by reducing costs. And that's why we brought this program to you today. It's on combining behavioral health and medical care for improved outcomes and profitability for ACOs. I feel very lucky to have with us today two guests that are with a company called Polaris Health Directions. And Mark Anthony is the president and CEO, and Mark Redless is their senior vice president for innovations. I'm going to have each one of them just quickly introduce themselves to you and some of their backgrounds so we can move on with the program. Mark?
Sure, John, and thank you. We're very happy to be part of the Flacco's presentation today. We can talk about Polaris a little bit later in the company, but my background is really as an entrepreneur and in developing new markets. Obviously, healthcare is a very tough market to work in. Healthcare, traditional medical care, and behavioral are two very old markets. The challenge is to try to use creative marketing and innovation to bring the two together, and that's what we're trying to accomplish. Mark?
Yep. Thanks again for having us. Again, my name is Mark Redless. As John and Mark have said, I'm the Senior Vice President here for Innovations, and our responsibility is really kind of evaluating and looking at the market from a product standpoint and helping enable systems, hospitals, ACOs, organizations really in connecting and monitoring and helping better manage kind of the behavioral health areas that maybe aren't always so focused on in a lot of these medical settings. So a lot of that conversation will come up throughout the next 45 minutes or so, but really excited to talk about it. So.
Good, thank you. At the Wharton School, I'm constantly approached by students and alumni that have new ideas, new programs, new services, and there's never been a better time in our healthcare system to bring some of these forward. A lot of them, however, are relatively new concepts and unproven concepts, if you will. One of the things that attracted me to this behavioral health and general medical combination is the fact that a lot of what's been developed is based on years and years of solid experience and solid research. I'm going to ask Mark Anthony to elaborate a little bit on that because there has been a very significant history of NIH grants and studies specifically looking at that link between behavioral health and general medical care. Would you address that, Mark?
Sure, John. A couple of things. First, there's the intuitive element of behavioral health and integrated care. Everybody we talk to, all the docs we talk to, all the clinicians we talk to, all the management level in healthcare gets that behavioral is an issue. You can't listen to the news, you can't watch TV, and not see something, issues, problems, crime that are related in some way to addictions or to mental health, whether it be even some of the gun control related things we're talking about. They're mental health issues. They're not things that are easily managed. They're not things that are cured. They really are managed in the long run. They're not getting a lot of attention. They're tough issues. And in medical care, The medical care providers are already buried in day-to-day management, taking care of their patients, managing money, systems, programs, all of it. It's a tough job. And now we're saying you've got to include mental in their world. It's a tough thing to ask folks to do, but intuitively people know it. The statistics that we provide are, this is 4 different examples of stats. We've got hundreds of statistics that we've collected over the years, and others have done in studies that prove that if you don't know what's going on in the head, you can't really take care of what's going on in the body. And then it drives the other question: what came first? Are my physical ailments, whether it be a long-term illness, whether it be related to obesity, is it because of my lifestyle and self-medicating, addiction-related issues, or is it because I got sick first physically, and that physical ailment caused my mental condition? Bottom line is you have to address both. It does improve outcomes. We know that. A good attitude improves outcomes, right? It does allow healthcare providers to shorten the term of care, and it does then improve margin, which is what everybody's trying to do so that we can provide better care. But that's basically what we're about, is helping people to understand that.
So the NIH studies, however, they've been, over a whole series of years now, been able to identify patients that have no previous history of behavioral health issues, but yet given their past medical history, their medication usage, helps to identify them as high-risk candidates. Is that accurate?
Yes, we've had 2 focuses over the last 18 years and about $15 or $16 million in NIH grants, and then private funding to do that. And there's 2 sides. First, you want to be able to identify a person that's walking in the door that looks absolutely fine, right? And 80-some% of the time, a doc could look at somebody and say they have no behavioral issues at all. They'll take an assessment, and 80% of the time, we're going to find out that they absolutely do have mental behavioral issues that rise to a threshold that require attention. Right? So it's not something you can recognize. So identify the risk and manage the risk. That's what these studies have all been about across a whole breadth of different service lines and areas. So it isn't just enough to identify it, then it's trying to do something that's going to change their behavior, whether it's how you manage their time, coordinate their care, drive them through that whether it's a cancer patient, driving them through the cancer process. How you manage them will absolutely impact their behavioral attitude, change their behavior, and hopefully give them a much better outcome and a better experience.
Excellent. Okay. Let me rephrase it a different way. Historically, we've not done a lot of this. We've not combined the 2. Doctors don't have the time, don't have the inclination. Patients come and they don't present with any obvious behavioral health type issues, so it's just kind of ignored basically. But with some of the changes in reimbursement, some of the recognition that by addressing these issues we can have better outcomes and lower costs, we're starting to see some providers, particularly the bigger providers, accept this, take it on, and address it in a very big way. Mark Redless, you've been dealing with several of these. Can you give us some background? Kaiser, for example, is one that you mentioned to me is taking this on. Talk about that a little bit.
Yeah, so and we're going to get into it a little bit more as we go as far as the big 4 kind of pieces, the themes that are happening kind of in your larger integrated systems. But you look at your Kaiser, which is, as John alluded to, a fairly large customer of ours that we work with, and we engage with them at a kind of an enterprise level. You're talking about a fully integrated system where you own your own facilities, you're managing and adjudicating care, and you're paying on those. So it's all about cost containment, but rationalization of those costs appropriately to make sure that your outcomes are in line so that you can expect to reduce that. So from a behavioral standpoint, they've really jumped out, those larger integrateds like Kaiser, and said, we're going to stay ahead of this game. We understand the relationship between behavioral and physical, and I should say in the medical side of things, and the identification, early onset, early in the cycle identification of behavioral issues, not just your classic depression, distress, and anxiety issues that you might get with really rudimentary but validated instruments, but beyond that in physical functioning, social impairment type areas, financial barriers to treatment, other barriers to treatment like transportation and childcare, getting to medical appointments, the stresses that puts on an individual patient in these situations, especially as they age, becomes really prohibitive to having successful medical outcomes. And they're getting that. They have to make those impacts. And we'll talk a little bit more later about what's driving that behavior in new subscriber and membership in those in those integrateds, and plans. But yeah, so hopefully that gives you a good feel for where it's going.
So it is starting to move forward, and when you look at the slide on the screen right now, it's understandably why people are concerned. You know, up to 70% of primary care medical appointments are for problems stemming from psychosocial type issues. And again, right now we really don't have any significant way, or have not historically addressed that in any way. Among emergency departments, high users, 56% were diagnosed with behavioral health problems. I don't think that's a surprise to anybody, particularly anybody that's worked in the ER. Nearly 75% of inpatient regulars, high users, have been diagnosed with behavioral problems. And here's one that I find exciting. Only 10% of healthcare organizations at this point are using any kind of advanced tool or analytics to help identify these types of patients and what can be done to improve their outcomes. Pretty significant information here. So with the Kaisers and the other groups that are moving forward, talk to me a little bit more about what they're finding or what results they're having. It's still early on, but the reason they got into it and what they're finding, I'm assuming, are very positive.
Yeah, I think right out of the chute, we've seen in the clinical setting. First off, we're seeing a real improvement in the orchestration of that care. So in the clinical settings, by capturing this information early and frankly often, and packaging it in a way that's really usable with clinical utility and medical administrative utility, they're now engaged in conversations with patients that are much more comprehensive, inclusive of complementary medicine in these medical appointments, and you're starting to see the eliciting of, oh, well, maybe this problem is stemming from something else, as opposed to kind of what the most obvious might always be. And that's allowing them to align really services within the integrated overall system appropriately to the patients at the right time.
Okay.
We can talk about and expand that in a little bit. But
the slide that's up on your screen right now is a really pretty slide. I like the colors. Mark, can you go through that and describe that for participants?
And it really is a summary of everything that we're talking about now in behavioral care, right? The idea is behavioral and medical is combined. That's integrated care. The way we're talking about it now, it's the head and the body. Take care of them at the same time, improves outcomes through behavioral health analytics. Right, and so that the bottom line is it comes down to the information being together in the same system. It's a process that says when the patient comes in through the intake process and on a regular basis, we engage them in a conversation electronically to find out what they're thinking, how they're feeling, etc. And we've got 18 years of study to show what kind of questions have to be asked and the way they have to be asked and when they should be asked. So there is a science just to the way you ask the questions and how you get meaningful information out of it. And then the ability to have that information in a place where the clinician can use it while they're looking at the medical data. What do I have to pay attention to? What can I ignore? If a person comes in and doesn't set any flags, nothing to worry about. But we have the data and we have the history. We may want to ask somebody to mute their phone.
Yeah, and then
we can hear somebody talking in the background. Could you mute your phone, please? You just do that by hitting *1. Thank you.
Right. So we're collecting the data as Mark's already said, on a regular basis, and we're creating a profile over time because mental issues, behavioral issues, they ebb and flow. Right? It's something that's managed. So it's important to be able to establish that. As we're helping with treatment and counseling with whatever they are, you can actually measure the response to that over time through this process of collecting continually the information. Then your analytics will help you understand your population, literally geographically, by illness type, etc. So you can understand the different service lines that you can apply, care, providing additional services that can be brought to bear to help that patient. And all of it at the end of the day, by capturing, helping people navigate through the process, as I mentioned before, keeping the patient informed as well as the care providers informed, and having a plan to intervene, key thing here, and a workflow. Now that I know, what do I do about it? 2 years ago, we were hearing from healthcare companies, I don't want to know because I can't do anything about it. I don't have resources. I don't have psychology. I don't have social workers. My navigators are jammed. This year, we're starting to see a change in that. Okay, now that I know, what do I do? How can you help me understand what's next? Who do I have to hire? What outside services do I have to get so I can provide the services to help these folks? So, and what you typically run into, John, is the group on the floor, they really care about the person. Their whole life is about the individual, right, and the value of that human life. And the business people are trying to keep the lights on and pay the bills. It's where those people come together that we're starting to see meaningful adoption to this and where we start to see greater outcomes.
You know, coming from the Wharton School, one of the things you're always looking at is the cost-benefit analysis, the financial returns. And this is a service that's still relatively new. And as I mentioned earlier, intuitively, you talk to physicians or pretty much anybody in healthcare, and they'll tell you the link is there, the costs are there from the unresolved behavioral health issues. But it's still relatively early in this process, so we don't have, I don't believe, or I haven't seen any hardcore results that will say, do this and you'll benefit from this economics. However, I can't help but believe that the Kaisers of the world, as sophisticated as they are, have not looked at this thing from an economic perspective. And even though they may not have actual numbers to prove it, I can't help but believe an organization of that magnitude hasn't looked at this, looked at the economics and said, you know, we don't know how positive it's going to be, but we know it's going to be positive, and it's the right thing to do for the patient.
Sure. For a couple things, I'm going to ask Mark to talk about Kaiser specifically, but generally, we have been looking very hard at ROI models. We've spent a lot of time and money talking to people about exactly that. And most execs are looking for a big number. If they're going to, make a lot of changes and cause a lot of pain, they want to save millions and millions of dollars. The ROI doesn't exist yet. It will. It's something that's going to be built over time, right? And this is almost like a secondary effect. But it comes down to progressive organizations that say, and Mark will talk to a couple of these, if I can change this, if I understand this, I can manage my care process better, and I know I can get practical savings in these areas. And so it's the early stages of an evolution toward integrated care. Once we have that information and data, we'll be able to model. It's still early, right, adoption. So Mark, if you could talk about Kaiser in particular.
Yeah, can we go down to some next
Sure.
slides or so? When John asked us to do this, and have this conversation with all of you, one of the things that we're always reflecting on is that we're spending a lot of time typically on both coasts, so we're getting a really good diverse kind of view of the large kind of integrated systems and large plans that are owning their own medical facilities and managing this stem to stern. A sense of what's really driving. So Kaiser's one, and then we have another one on the East Coast, but that are really big that we're working with. That are what's driving them to look at behavioral health. And I think some of those lessons learned really play very well into some of the considerations that you all might have. So if you could just click onto the second one there. So this may be less important to all of you, but I mention it because kind of these are the four really big drivers that we're seeing in integrated plans and systems. And it gives you a sense of kind of the modeling and financial aspects of what's going on behind the scenes for them. This first one being large purchasing groups. They're buying, obviously, these plans and these in aggregate. You're talking about tens of thousands, if not more, plans at a time for their employees and families, and they're looking at bulk purchasing deals on both the West and East Coast. and looking at what is affecting their premium price. So what is affecting pricing of their plans and what's contributing to risk amongst their employees. And this migrates later on to the age, but when you think about controlling premiums, some of the biggest pushes that we're seeing from large purchasing groups, which is a good early warning sign, early indicator of where trends are going, is around behavioral health and gold standards in behavioral health, monitoring and measurement, and early insights. So a lot of what is driving plans to take a very hard look at this and incorporate behavioral health, both assessment, screenings, and ongoing monitoring, and finally treatment into their programs, is that they're getting that push from their own really large purchasing customers. So that's one of the big pieces, and we're seeing that at Kaiser. I don't know if I can do it. The next one is kind of like motherhood and apple pie. We've been talking about this a lot. But this idea of hospitals and health systems seeking to reduce costly readmissions. You see in the quote, the quotation, the statistic below, that 63 million visits to physician offices, and then take the rest of that primary care setting, outpatient and emergency side. 63% of those are primary diagnosis was a mental disorder. Everything from loneliness, depression, distress, anxiety, any number of different behavioral addictions, as Mark Anthony had talked about in the beginning. Those are really driving it, and we're trying to drive out an understanding and an alertedness to these problems earlier in the admission process, or earlier in the identification process with a lot of these patients, to again reduce costs on the backside. Next one. Yeah. This one I think will have particular will ring particularly true, I think, in your environments, which is this idea of alignment. So alignment of care. You've got a lot of different ways to treat a behavioral health issue, especially as they migrate into the 50-plus age group, 60-plus, 70 and beyond. You're dealing with a lot of different types of psychosocial-based issues. And what we're seeing with the larger integrated plans like Kaiser is this real push towards aligning both the level of treatment that they're getting in the behavioral health area, as well as the intensity or frequency of those treatments. So everything from just basic education around behavioral health being the most modest approach to treatment, to intensive outpatient being kind of the upper tier of that level of treatment. What we're doing with technology and with screening and assessment tools is really identifying who belongs at what level, to not only appropriately treat the case, but appropriately cost that case, right? So we're looking to keep costs down and appropriate for the level of demand on those behavioral health issues. That's one. And the last one is, I should have just summed it up, take at least one comorbidity off the table. One of the things that Mark Anthony mentioned in the beginning was this, with obviously integrated care. You've got medical and behavioral in this. Well, if someone has cancer, if someone has a chronic disease that is being treated, it's terrible enough. But it's even more terrible when coupled with depression, distress, anxiety, or the myriad of other behavioral issues that we talked about here. And when those are paired together, you're seeing a massive increase in those outcomes becoming less than optimal from the medical treatment side of that. So the idea here is that if we can go from not curing the behavioral health situation, but managing it in a better way, getting it from the high severe category into a moderate manageable category, you really are unleashing the power of being able to make some real progress on the medical comorbidity in that case.
Let's take this back to a real practical level.
Yep.
I'm a physician practice. I have a good array of patients in my practice, and I decide to utilize this kind of an analysis. What am I getting? I mean, I'm hoping it's more than just a list of patients that are high risk. Walk me through that process. So I've got a practice, I utilize a service like this, and what am I getting?
Well, one, you're not just identifying high risk, you're identifying really where the risks are, right? So I mentioned a couple of those, but if you look at kind of 6 or 7 dimensions of behavioral health type issues, which aren't all treated the same way, aren't necessarily all going to be dealt with the same way, but some of them being obviously depression, distress, anxiety, what would be considered the big 3. But some of it is social functioning and social impairment, and, loneliness that contributes to depression. So a really good instrument, a really good tool, like what we're talking about, is going to identify those areas so that you can really appropriately refer out or control kind of where they're getting treatment and with what level of intensity and appropriateness.
So as the doctor, I have Mrs. Smith coming in to see me this afternoon for a 2 o'clock appointment, and she's going through this screening process. So you're going to be providing me as the physician
Yep.
with more than just an indication that this is a potential problem patient, but with some very specific direction in terms of what those issues might be or what the resources might be required to care for her better.
Yeah, that's right. That's right.
And as a physician, then I'm kind of digging into this a little bit to try to confirm and therefore take that into account as I treat her medical issues as well. Okay.
Well, this is where the whole idea of bundled care and the ACOs come in. Behavioral health in a concierge type of an environment, in a telemedicine type of environment is perfect because it gives information and it begs a response. We could have primary care docs or emergency rooms or oncology centers or you name it, using this and getting the information and doing nothing. I got it, thanks, check in the box.
Mm-hmm.
I can ask you 6 questions and say, hey, I asked them, they said they felt fine. But the truly integrated model, the right questions are asked, the right information is provided in a way that it can be used, and the provider has to make a decision that they're going to use it. They're going to manage them. It could be that I have a patient that's coming in for treatment in oncology, and because of their addiction issues, they're always late, or they don't show up. Well, every time they don't show up, it costs me $15,000 in the medications that we pre-mixed for them. Well, that's a no-brainer. I'm going to make sure I know that guy, what his story is, where he's come from. He's going to get more attention. I'm going to monitor better. I discharge somebody from the hospital or from a treatment, and I know that they have other types of mental issues, whatever they are. I'm going to pay closer attention to them to make sure that they don't come into the emergency room because they were depressed or didn't take their medicine, or they're not readmitted because of something they did related to a behavioral problem. So first you got to know, and then you got to make the deliberate decision to manage it better. And in spending the time and a little bit of money to do that, the idea is you're saving a lot more time and a lot more lives. Mm-hmm. That's really what it comes down to. You're spending a little bit of time and a little bit more energy to save time and money in the long run.
If you can endeavor to treat behavioral health more from a wellness perspective of prevention,
yes,
and avoid the triage scenario of emergency room visits by getting ahead of this, even a small percentage of overall kind of portfolio of membership cases, you're going to see really, really incredible benefit, because the amount of triage costs can be 2, 3, 4, or up to 10 times the cost of you're talking about early identification and group therapy or educational type programs. It's really a proactive approach to cost avoidance in the emergency room and kind of hospital admission setting, right?
And this is really what the whole government shift from fee-for-service to value-based is pointing to. Bundle payment, for example, I mean, you're encouraged to do all of these upfront preventative type issues, spend the money to make them happen, yes, and the benefit comes from the savings down the pike. And when you look at the average ER visit costing $2,000, $3,000, the average hospitalization or readmission being $8,000, $10,000, $12,000, it's not hard to see where those benefits will come about.
Sure.
So what do we need to do as an industry to incorporate more of this into the system? What's happening now to encourage this?
Well, it's our experience that we're still early in the adoption phase. And it is going to be an evolution like everything else in healthcare. It's an evolution versus a revolution. Our government has been slow to adopt it here in the States, whereas in Europe they're very progressive about it. and still they have their issues. But here, right now, it's about awareness and education. We have a whole series of cartoons that we have going out to executives talking about the elephant in the room, trying to use humor and logic, the intuitive logic, to raise awareness to the importance of this. And what we're then trying to do is get early adopters who recognize that this is something that they need to address. And while it may not be, $100 million savings, there's still an important savings and an outcome, an improved outcome that drives loyalty from patients, which of course is another major issue. We're trying to drive that discussion among people and early adopters, then prove the model that others can look at and see. And in doing that, we're trying to drive standards for what is integrated care. We have the 18 years of study to prove what should be being done. It includes mobile, wearables, all those things that engage a patient and keep them with you. And if we begin, and John, I think this is a very important piece, I keep referring to this as behavioral health being the camel that has its nose under the tent. There's so many things on the medical side that need to be improved, and they need a reason, they need an impetus. Behavioral can be that. New systems, new mobile capabilities, new wearable capabilities that collect medical as well as behavioral and send them in a combined way and set flags and EMRs in a combined way that are integrated into the EMR to make it easy to use. That's what we believe has to happen to ignite this, to get more and more institutions to spend time on it.
Now, behavioral health historically has not been referred to as much as it potentially could, because we've ignored to a large extent the behavioral issues or been unaware of them. And there's also been a concern by a lot of providers as to the volume or the quality of behavioral health services that's out there in the community. Who do you refer to, when you have a patient with a problem? We're talking about a process here where we're identifying a lot more people who need behavioral health interaction. So for a practice, the ones that are early adopters into this, are they reaching out? And like with bundled payment right now, you see hospitals setting up preferred provider networks of nursing homes and home health services. Are we going to be seeing preferred networks of behavioral health providers as well? And is that something a physician practice is going to have to do if they adopt this kind of an approach?
The short answer is yes. And in some cases, in some of the large systems that we're dealing with that aren't necessarily integrated but are trying to manage patient flow right now and volumes, one in particular on the East Coast here that we work with, is starting to experiment with bringing their behavioral health team members into the primary practice setting once a week, twice a week, 2 afternoons a week, to start to triage issues early on in the primary care setting before it gets to the chronic care specialty kind of acute situation where you're dealing with an expensive acute medical condition where now they've got to figure out how to refer out to behavioral health specialists while treating cancer, while treating a neurological disease or an orthopedic issue, a hip replacement or something to that effect. We're catching this. If we catch it earlier, we can emphasize things like group therapy, right? Where we can be more efficient with behavioral health time, right? Because if we're sending everybody to an intensive outpatient treatment scenario, we're going to cripple the system, right? There aren't enough behavioral health professionals to handle that kind of IOP type treatment. So it's imperative, and one of the things I wanted to, hopefully this kind of links the two together, one of the things I wanted to piggyback on what Mark was saying was this idea of, one of the things I would say is the most disappointing for our team from getting out in the market is there's such an emphasis on behavioral health that we're seeing in specialty areas. Orthopedists are saying we're worried about if people are depressed because they're laid up from their hip replacement for maybe they never get off of it because they can't recover. Or they have cancer and they're going through a horrible treatment and it's exacerbating it. Getting it early, getting it before we get to the chronic condition situation really changes up the metrics of the system and its ability to handle the influx of really an increasing level of behavioral health patients. They're not going away. They've been hiding, but they're there and it's growing. We're having more problems in this country of depression, not fewer. So,
Am I correct in assuming that some of the behavioral type issues we're talking about, particularly the depression, the anxiety, they're the result often of non-behavioral health issues, but environmental issues, if you would.
That's right.
Not having a babysitter for the kids, or having to miss work because of this, or all the stress,
Financial
financial
Life.
Yeah, life in general. We all experience that. So I'm wondering whether part of the solution here, when we identify these patients, particularly if you identify them early on, if it's an anxiety issue or an environmental issue, as I'll call it,
Yeah.
they're addressable with non-behavioral health professionals. They're more life issues, if you would. But having a process in place to help people with those would help avoid the anxiety, avoid the depression, and avoid all the negatives that come with it.
Look at some of the people to answer that, look at some of the people who are coming to us first. Oncology, right? That was pretty easy for breast cancer in particular, brutal. But look at the others that have really come out of the woodwork at us. One of them is bariatrics.
Mm-hmm.
In certain parts of the country where culturally it's acceptable, the male prefers this, the female looks like this, so there's weight issues, right? And then it becomes a mental issue and a depression issue, and then it becomes an addiction issue. And so we can address the issue at the root. That request is we have specific populations that we want to assess behaviorally and begin to address their cultural issues with the behavioral information that we get. Mm-hmm. That is a very practical way to tackle an enormous problem.
Two quick questions that come out of all this. One is, how are you actually assessing an individual? Is it through their medical record and pharmaceutical information? Is it a survey they fill out at the doctor's office? Where are you getting the information to then make the analysis to say, here's the issue?
So Mark mentioned our 18 years of NIH-funded research, and we've done a lot of work in this area. And one of the biggest areas that we've done work in is on how to capture this information, right, and validating that. And for those who may or may not know it, there's real statistical evidence and validation around the idea of self-reporting and the level of honesty by patients in self-reporting. They seem to be very willing to tell an iPad their deepest, darkest secrets and not tell those same dark secrets to the nurse navigator or their physician or even their family physician. So self-reported is, in most of the cases we deal with, and really the best practices in the industry is all around self-reporting via some type of electronic mechanism, obviously for efficiency and scale. But we typically use things like iPads and tablets. Some organizations are using workstations on wheels and things like that. There's some move towards getting these patients even before they come in. From a mobile standpoint, so being able to distribute these kind of capture via these assessments being captured on their mobile devices and smartphones. So, but in almost every case, I would say self-reported assessments and screeners are really the way of the best practice right now.
So I'm coming in for a 2 o'clock appointment with my doctor. You're saying I will have an iPad and ask a series of questions, and then that will automatically give the doctor what he needs? Does he get it before I walk in his office then?
Yeah, if you're working with a really good group and they're integrated on the back end, putting the systems in place, these typically are going to be captured in registration or the waiting room or early, even in the exam room before the physician walks in. Upon completion, usually about a 30-second to sub-minute round trip into their own EHR. And delivering those reports that are providing a fully enumerated set of guidelines and decision support tools for that physician to evaluate in the appointment with that patient.
That's impressive.
But even more, John, if you're a managed service and you're directing the patient to go here, here, and here, concierge type, they could take this at home.
Yep.
And they could take it on a regular basis at home. And you can begin to maintain a profile. More than that, by combining the medical and the mental data from a wearable done remotely, we can actually proactively indicate to a professional, whether it be medical or behavioral, that a person needs attention. That's the real value of integrated care. You already mentioned it before. That's really what it's about. So it's the duration of care. You don't just do it once, say, I got this guy. Everything changes. Life changes.
Yeah, it sure does.
And we're even going as far as to work now on genetic models, very progressive, that show the impact of behavioral on the genetics of a person on a daily basis. Those genetics then act as triggers for medical issues. That's how we believe, how tightly we believe it's integrated. As soon as we prove that, we believe there'll be an even greater adoption.
Very interesting. One last point I want to make, and then we're going to open it up to some questions, and that is I'm seeing a tremendous increase in the use of telemedicine for behavioral type services. And again, I think that's important in today's environment because of the shortage of behavioral health professionals, and particularly in certain areas, rural areas in particular, and the ability to use telemedicine to provide needed services. Are you seeing that? Is Kaiser looking at that at all, or any of the other providers you're working with? Has that come into play yet?
In pockets, I would say. I think we'd like to see the trend be more than it is, probably, and I think it's mostly impaired by their own EHR systems in most cases, right? So some of them are putting brand new EHRs in, and they're already in the box, not able to leverage telehealth because of some of the choices that have been made. There's a lot of work in the underlying plumbing right now to allow that to be an easy connection between whatever telehealth choice is made and whatever EHR you've chosen as a system or hospital. So we think that that's going to be a huge part of the behavioral health wave of capturing via telehealth.
We absolutely do. The bottom line, though, for telehealth is there's 9,000 plus telehealth organizations in the United States, all fighting for the same dollar,
right,
and trying to be relevant and being embedded in a solution, right? The number one keeps buying up all the competitors. Yeah. So they're struggling with their own systems. The response that we get is, we're definitely interested.
Okay.
As soon as we start paying for the lights and things, we'll get back to you.
Laura, how do we open this up for questions now from the participants?
Bear with me 1 second. Let me make a couple of adjustments here.
I'd encourage you, if you have a question, you've got two of the nation's experts here, and I think they'll be very happy to respond to questions you might have. Just interesting point while we're waiting for Laura. I met this morning with some representatives from a company that's working with one of the big Blue Crosses this morning, and they're caring for 2,000 of their high-risk candidates. And their comment to me when I mentioned behavioral health was that, oh my God, that's such a big issue, we don't know how to deal with it. So there's a real recognition right now that the whole behavioral health component is impacting negatively on medical care and increasing costs, decreasing outcomes. So I raise that. I want to bring it to your attention. I just wanted to make you aware that the topic we picked today is really, I think, a very relevant one. So does anybody have a question they'd like to ask of Mark or Mark?
You can pick your mark.
Yes.
Okay. Looks like we do have a chat question coming in. Thank you kindly for your time and very interesting presentation. How would focusing on medication adherence help mental health? It seems like many mental health patients have high rates of noncompliance.
Yeah. It's a really great question. Obviously, we're seeing it in large scale in our addictions area. So just to give you some more specificity to that, we're working across a very large membership population, technically on 2 coasts, but the bigger being around 3.5 million members served in the addictions area of Southern California. Across, I don't know, something like 20 sites and just hundreds of professionals. And our tools are being used much in the way of examining, obviously through self-reporting, that idea of medication adherence. So one of the massive focus areas in those, not just addictions, but in pure mental health in those settings, is in fact on medication adherence, and talking through what are the barriers though to that medication adherence, right? Because even if you see a failure to take those medications as prescribed, there's different reasons why those are happening. It could be cost related, where they're cutting pills in half because it's a tier 3 drug and they're paying enormous copays for that. It could even be how it's manifesting physically for them. Sexual dysfunction, even just physical dysfunction overall, social removal of oneself from kind of social interactions as a result of just how that drug is making them feel. Hopefully not, but and then you've got prescription conflicts. This doesn't seem like this is interacting well with what I'm having. So the ability to capture through assessment and screener what in fact they're taking, because believe it or not, as awesome as some of these EHRs are, they don't have any idea all the medications that one is taking. And our best chance through self-reporting is to get those medications listed properly so we can start to get a lay of the land of, in fact, not only just what they are and aren't taking, but what they're supposed to be taking in total. So I can tell you, we and our customers, our large organizational customers, are using these types of tools to identify not just if they're taking medications on a broad basis, but really down to the level of what they're not taking and why they're not taking it, which are really the important things from a behavioral health standpoint. I hope that answered your question.
I'm going to jump in with a comment too, because I've done a lot of work with medication compliance, particularly in the elderly. And some of that's behavioral health, some of it's dementia or other issues hitting. They forget to take their meds, or they forgot they've taken it and take it again and again and again. The other reality is we find a lot of people, particularly seniors, that go home from their doctor or their hospital stay with a list of 4, 5, 6, 10 medicines they might have to take, and they've got another 5 or 6 in the medicine cabinet that they take on their own, the self-administration.
Yeah, yeah.
I was shocked to learn a little while ago that about 65% compliance rate is what we see in the general population, even among transplant patients.
That's a shocker.
65%. And there's a whole bunch of reasons. Financial is a big one. Sometimes they're starting to feel better and they don't like the way the med might make them feel or not, so they stop taking because they're feeling better and it only makes it worse. So the whole medication compliance issue is a huge factor. But identifying early on who has the problem, who's not complying, and again, it's a big chunk of the population.
Who's likely not to comply.
Yeah, who's the most likely not to. And maybe putting into place some of the devices that are out there. There are some home-based medication dispensing systems that will alert you when it's time, identify if you didn't take it, call you if you didn't take it, call your support person if you didn't take it. So I would encourage looking at some of those devices if indeed that's a problem in your market. Any other questions we can answer? Well, I'm going to ask Mark and Mark to give us a quick wrap-up from their perspective, and then I have a few comments, and we'll call it a day.
Let me start. Yep. So I think, the moral of the story for me would kind of, as takeaways, especially in the ACO context, is really this idea of emphasizing some level of comprehensive screening and assessment early on in the primary care setting, and trying to get at some of these underlying issues that will manifest, especially in the aging population that you're serving, manifest themselves in hospital admissions and hospital readmissions and emergency room admissions. I think that's the lowest hanging fruit in this situation, and it's one that you can see really manifest pretty quickly. So just something to think about. Okay.
Mark, I'll say any opportunity to talk to the community in general, healthcare community in general, about behavioral integrated care with medical is an enormous opportunity for us, and we really do appreciate it. The chance to talk about the value of it and where we see it going, but especially to the ACOs who are trying to be progressive and to provide a path to bundle care programs, to more efficiently deployed programs. It should be the best place for programs like this to be implemented. And piggybacking on what Mark said, if you take anything away from this at all, just the ability to know, to identify the risk, and then to manage that risk, and then to maintain a profile through the new capabilities that integrated care bring in. Again, I keep emphasizing mobile, wearables, et cetera, combined data. It absolutely should drive an improvement in overall outcomes and cost, but especially in an ACO bundled care model. It's just a matter of finding those that are progressive, that have the ability to implement something and to take advantage of it. And they're the folks that we're looking for, and that's the data that we're trying to validate.
All right, Mark and Mark, thank you so much for your time today. I have just a few last comments, and that is, you know, ACOs historically have been very challenged, if you would, just keeping up with all the Medicare and the government regulations, and there's such an administrative burden, if you would, keeping the day-to-day operations going. And looking into new areas like this, or areas that have not been emphasized in the past, is added work, added effort, added cost. However, I think our whole healthcare system is changing in this direction. We're quickly moving out of the traditional fee-for-service into this performance-based, and there's tremendous background in terms of research to show that by addressing behavioral health, we are going to be doing a better job addressing and keeping the cost down for basic medical services as well. So I'd encourage all of you to give this some thought, see how it might apply to your ACO. If you have questions, the last slide has some contact information for the folks at Polaris, and they are national leaders in this, so I'd encourage you to give them a call. Thank you so much for your time. Thank the Florida Association of ACOs for allowing us to do this presentation today. Have a great day, and again, Happy New Year to all of you.